1. Good afternoon and good morning. Welcome to NCSL's COVID-19 Guidance for Easing State Restrictions webinar, one in a series of webinars on the federal and state responses to COVID-19. My name is Laura Tobler, and I will be moderating the webinar for you today. Thank you all for joining us. As coronavirus cases increased throughout the United States, many states and localities took actions, many that you're fully aware of, to limit the spread of the disease through implementing social distancing guidelines, putting limits on personal movements, and closing certain businesses. Now, state leaders and public health experts are working to figure out when and how to reopen states. This webinar focuses on guidance for reopening businesses and gathering places, as well as the considerations for states before doing so. We hope today's webinar answers questions and provides new information for you. Throughout the webinar, you may submit your questions for our experts by typing them into the audience chat box in the lower left corner of your screen. Please do this throughout the webinar. We'll get to Q&A at the end of the webinar. If you wish to download the slides for today's webinar, click on the Event Resources tab where you'll find a PDF version. The tabs are found just above the presentation window. Another tab is labeled Speaker, where you can read the bios of today's speakers. You can access these tabs anytime throughout the presentation. If you have trouble downloading the presentation and other resources, please email me at laura.tobler@ncsl.org and I will send them to you. You can also send us a message through the audience chat box. Today's webinar is being recorded and will be available on NCSL's website within a few days. The National Conference of State Legislatures is the bipartisan organization that serves the legislators and legislative staff of the states, commonwealths, and territories. NCSL provides research, technical assistance, and opportunities for policymakers to exchange ideas on the most pressing state issues, and is an effective and respected advocate for the interests of the states in the American federal system. Please visit our COVID-19 webpage where you'll find in-depth resources related to many policy arenas impacted by the pandemic. That page just keeps getting bigger and bigger. Today we have 4 presenters who will share their expertise with us. Remember to click on the speaker tab to read their bios. We will hear from the White House on their guidance to open up America, from the Association of State and Territorial Health Officials and the National Governors Association on their roadmap to recovery, a public health guide for governors, and from a leading public health expert on lessons learned from the evidence and experiences in other countries on easing restrictions after a pandemic. Our first speaker is William Crozier, Special Assistant to the President and Deputy Director of the White House Office of Intergovernmental Affairs. Thank you for being with us, William. He will talk to us about opening up America again, guidance from the White House. I'm going to turn it over to you, William.
Thank you very much, and I really appreciate that introduction and for NCSL having me on the phone today. I feel like we're doing a lot of outreach and briefings with state and local officials across the country, including many that are on the phone today, and appreciate your leadership at the state and local level. I believe as of today, the White House has held 183 briefings touching over 85,000 stakeholders since January of this year, and hopefully you've been able to join those. But on behalf of the President and Vice President, I want to thank you for your partnership to meet these challenges with solutions at every level of government. As mentioned, my name is William Crozier. I'm Deputy Director of the Office of Intergovernmental Affairs at the White House. Undoubtedly, many on the phone have received an email from me at some point, hopefully, since I've been here since July of 2018. Our office manages the relationship with state and local elected officials, and I personally work with state legislators around the country. country. Just as I speak now, the President signed the next stimulus bill, $500 billion that's going to go out to state, local, and private stakeholders across the country. That includes $320 billion for the Paycheck Protection Program, $60 billion for the rural and minority-owned companies specifically, and $75 billion for hospitals, among other distributions of funding. But more importantly, I want to talk about the guidelines. On April 30th, the 30 days to stop the spread that the President released, the efforts are paying dividends, and it is critical that everyone continue to follow the guidance, even as we see a leveling out of cases in some areas of the country. And your voice as a local leader is vitally important to echo these important guidelines and tailor them to your community and culture. Last week, the President released guidelines for opening up America again, providing a plan for rolling back social distancing measures and reopening the country's economy in several phases, depending on location. Recognizing that no state is the same, the guidelines outline 6 metrics states should consider in crafting their own plans. These guidelines empower states to tailor solutions for reopening based on their own unique circumstances. And 2 important metrics of those 6 metrics are demonstrating that COVID cases over a 14-day period are declining in a robust and strategic system for testing. The guidelines also outline suggested responsibilities and capacity building into a reopening plan that state and local leaders should consider. That includes protecting workers in critical industries, particularly protecting the most vulnerable, those who live and work in senior care facilities, and having a plan for testing symptomatic individuals with a focus on vulnerable populations. The federal government will continue to work with governors across the country to ensure that they have the equipment and the supplies and the testing resources to reopen safely and responsibly. On Monday, we shared a list of all the testing capacity in each state with every governor. The Vice President has been in regular contact with governors on this issue and is on the phone currently with 53 governors talking about this important discussion. As of last night, the U.S. has now tested 4.69 million samples, which is more total tests than the following nations combined: Australia, Austria, Canada, France, India, Japan, Singapore, Sweden, South Korea, and the United Kingdom. And as part of their reopening guidelines, states should be making full use of the vast testing resources available to them, to include leveraging the full capacity available through the commercial laboratories, in addition to the capabilities provided through state laboratories. Last week, the President announced a bipartisan group of American leaders that will work together with the White House to chart the path forward towards a future of unparalleled American prosperity. These groups will produce a more independent, self-sufficient, resilient nation as we work in partnership with state and local leaders. I'd also like to highlight that through the CARES Act, which I know many of you are familiar with, that we have more than doubled the funds available through the President's emergency and disaster declarations to help state and local and tribal leaders effectively respond, in addition to adding the $45 billion to more than double the disaster relief fund. So I hope that that's helpful in providing an overview of the guidelines. And I think, as I mentioned, and the President has mentioned, this is governors and working with state and local leaders in developing these guidelines and reopening plans, and the federal government supporting them in this effort. As we always say in the White House, in our office, response to the pandemic is locally executed, state managed, and federally supported. We look forward to working with many of you on this phone, and I know having reviewed and talked to many of you as well, states from across the country, Michigan, Pennsylvania, Utah, Wisconsin, in between, are actively working and looking at their reopening guidance and plans, and we want to continue to be a good partner. So with that, I'm happy to take any questions.
Thanks, William, for that terrific update on what's happening at the White House and the information that you shared about the guidance that is out there for everyone to see, correct? I mean, people can access that guidance by going to the White House website. Can you tell them how to access that guidance?
Absolutely. The guidance is online, and I'm happy to share that that web address with you to access that. I can share it with NCSL. Also, if you'd like to get on our distribution list, to reach out to me directly, I can give my email is william.f as in Frank, .crozier, C-R-O-Z as in zebra, E-R at WHO, .eop as in Paul, .gov, but also NCSL can provide that as well, and then I can provide that web address as well.
Okay, William. So how much of the $25 billion for testing in the new bill will directly go to states to use at their own discretion for testing?
That I will need to get back since the president just signed the bill. I know it will be operationalized, but with that specific question, I don't want to speak out of turn. So I want to make sure I get the correct answer on that. So I'm happy to follow up on that directly.
Thanks for that follow-up. For those that are listening and curious about the answer to that, we can get that to everyone after the webinar. So can you tell us how PPE access is being factored into plans to reopen services?
In personal protective equipment?
Correct.
Okay. No, absolutely. And I think, a review of the guidelines is calls for, I think, there's two foundational, there's 6 metrics, but, really 2 I really want to highlight. And, one is around the importance of building up your testing capacity and also contact tracing, not only at the state, but at the local level as well. On our national briefing call yesterday, Dr. Tammy Burks with HHS specifically talked about this, as did Dr. Redfield on a separate call, about the importance of local communities and states working together, looking at those plans for how they're going to maximize their testing, but also about how they're going to implement contact tracing, as states begin to reopen. And PPE is an important component of that. The administration is providing direct support to states on PPE, and that's through the Strategic National Stockpile. If you have not received, we're doing state-by-state fact sheets right now to illustrate how many PPE resources states have received to date, but also all of the other actions that the federal government is undertaken. I'm happy to share those directly with you, but another important component of that PPE discussion is something you may have heard of called Project Airbridge. Project Airbridge is a coordinated effort by the federal government led by FEMA and HHS to bolster supplies in the private sector supply lines. And these resources that are coming in through Project Airbridge are going into your states. They may not be going directly to, say the State Emergency Management Agency, but they're going into private sector supply lines in the state that are then flowing to, stakeholders, state and local governments, hospitals, first responders, et cetera. So there are really 2 key components to that. So I'm happy to provide more perspective on that and also the state-specific fact sheets for more transparency.
Thanks, William. We are going to return to our next presenter, but thank you so much for answering those questions right after your presentation. We asked William to do that because he may get pulled away. I'm hoping he can stay with us till the end and be available for some additional questions.
Absolutely. I'll stick around, and I appreciate your partnership and look forward to hearing the rest of the call.
Thanks so much. So our next presenter is Michael Frazier, Chief Executive Officer from the Association of State and Territorial Health Officials. He's going to discuss the public health infrastructure needed to limit outbreaks. Mike, the screen is yours.
Thank you, Laura. And I did just post a link to an ASTA website, but it has your name on there. I'm not trying to impersonate you by any means, but I think when I dialed in, I got your account. So folks are interested in the issues that I am sharing and some of the funding summaries specific to public health agencies in particular. You can find those at that link. And Steve, just so you know, it was me, not Laura, but I don't want anybody to get confused or blame Laura if there's any mistakes. Thanks for the chance to be with you. I am going to move to the previous speakers' actually remarks on opening up America again, and just remind everybody that that plan does exist, and obviously there are some great sort of top-line messages about reopening, as well as some real specific metrics, and want to make sure everybody has those and is able to get those, and I'll refer to those in just a sec. The reopening and this gradual restarting of the economy and our work and social lives again is really based on three things. And in this blog, again on the website, you'll see what those three things are in more detail. But it's adequate capacity to test, it's contact tracing, and it's a public that is willing to go along with further mitigation if we see new outbreaks. Along with testing is the issue of PPE, is the issue of having enough hospital healthcare worker capacity to address any surge. Along with public compliance or acceptance of community mitigation is the role the policymakers play in sharing perspectives and communicating risk. But the contact tracing issue and identifying positive cases and then making sure they're linked to care and that they are isolating, and then linking with the people they've had contact with, that's a core public health function. And I think it's important that everybody realize that the function of contact tracing is not new. Your health departments do it every day. They've been doing it for years. We support contact tracing efforts in pretty much every local and state health department. What we need now is massive scale up of contact tracing activities, again, because the novel coronavirus has spread so quickly across the country. The numbers that we're talking about in terms of this outbreak are huge. And I think some of the seroprevalence studies from New York indicate just how widespread transmission is and has been. So we're really focused on contact tracing. The testing issues, as William mentioned, these are playing out federally, state by state. We all know that there's mixed ability for comprehensive testing at the local level. That's playing out in your states now. But in terms of contact tracing, we have the knowledge and we've got the skill. We just need the numbers to implement. And these are two reports that we've done over the last few weeks at ASTO. Again, these are all available online. A national plan to enable comprehensive case finding and contact tracing, as well as a coordinated national approach to scaling public health capacity for contact tracing that I hope you all have a chance to just skim. The bottom line is both of these reports, one that we wrote with the Johns Hopkins Center for Health Security, as well as our own, reference a number you have probably all seen in the press, which is an estimation that we'll need about 100,000 contact tracers to meet the initial demand as we gradually reopen and identify potential positive cases and trace their contacts. 100,000 is a lot. It's not the biggest number. There's others based on some experience looking at China and other countries that suggest we may need more. In the back of that red report, a coordinated approach, you'll see a state-by-state rundown of just some basic numbers for your state, estimating the number of contact tracers needed potentially. The contact tracing workforce in the states right now is small. Our disease investigation specialists that work primarily at the state and local level in the HIV STD programs is estimated to be 2,200. So we're making a huge jump from 2,200 skilled professional disease investigators to a scale up of 100,000 lay or paraprofessional contact tracers. And what that means for your state is going to be very different. Implementation in a large state with small population, your needs may be very different from a small state with a large population or a large state with a large population. And every county, city, and state is currently in the process of planning how they're going to ramp up contact tracing activities. again, this is just one of the strategies, and Hamy's going to share a little bit in the roadmap to recovery that NGA and ASPO worked on together. But one of the summary points in the roadmap is the need for quick recruitment, selection, and hiring of contact tracers. And our first way of doing that will be to look at who's in agencies today that can be redeployed, and then who in the community may have the ability to do contact tracing but potentially have lost their jobs or are willing to engage in this effort. You'll see why it's so important when we see this next slide, boxing in COVID-19. The strategy here, and this is adapted from a report that former CDC Director Tom Frieden has shared in online at his organization's website, Resolve to Save Lives. The boxing in strategy means basically you have to test widely to find positive cases. You need to isolate those folks and make sure that they are linked to care and have what they need to stay home for 14 days. You then need to find the folks that have been connected with that individual, that infected person, and I think the emerging guidance on that is everybody who's been in close proximity within 6 feet of that person for at least 30 minutes over the last 48 hours. That's guidance I've just seen in terms of draft that may change before it's finalized, but that gives you a sense of what all of this will be like in terms of numbers. And then those individuals are quarantined, again, to help stop the transmission. And this boxing it in strategy over time, the theory is that the smaller and smaller those boxes will be into the future as we gradually contain the virus and hopefully see a vaccine in the next 12, 14, 18 months. There's various ways that your state is organized in terms of public health, and the public health infrastructure varies dramatically across the country, both in size and scope. There's lots of different ways that states can organize their contact tracing activity. One of the things that we were watching was the early development of a community tracing collaborative out of Massachusetts, where the health department, the healthcare authority, the insurance plan for Massachusetts worked with an NGO, a non-governmental organization, Partners in Health, to quickly deploy their resources to build a cadre of contact tracers, which, by the way, in these times is primarily based in telephone and email. In sort of normal operating procedures, it's telephone, email, and person-to-person or door-to-door. And in some cases, in some places, that will have to be managed that way. They, I believe, had a goal of hiring 1,000 contact tracers, and they had 17,000 individuals apply for those jobs the last time I heard that story. There's other states taking different approaches, and as I mentioned, a lot of this is done locally in the local health departments. But I think it's important when we're talking about contact tracing just to pay attention to the fact that there is an existing workforce, a professional workforce called disease investigator specialists or disease intervention specialists, depending on your state. Those DIS are currently working in states, and they can serve as the mentors and trainers of these new contact tracer positions that could be lay or paraprofessionals. They may be folks, as I mentioned, who are medical assistants, community health workers, community outreach workers, linkage to care coordinators in a health plan. There's lots of folks who can do that kind of work. And those two tiers are also supervised and working with a team of healthcare public health professionals that are the clinical or epidemiological or surveillance specialist positions. So we're not talking about 100,000 epidemiologists. We're talking about 100,000 lay contact tracers that are then will be in need of training quickly, obviously, and supervision and mentoring, as well as a link to the healthcare system and to the overall public health agency capacity to do epidemiology and surveillance. This is a state, territorial, tribal, local, federal activity because, again, this all works out differently in every state. And so we're really, again, working individually with states to understand what their plans are, how they plan to approach this, while we simultaneously try to prepare guidance that everybody can use and can certainly serve as resources across the country. Finally, I just wanted to point out that there's a lot of talk about recovery and bouncing back, and I'd just like to put it out there that the public health system, as many of you know, has eroded over time. We're obviously seeing the consequences of some of that, and as we approach the COVID response, we're very aware that there is a need to bounce forward, not just back, and think specifically about how do we do this right for sustained public health capacity for the long haul, not just the next 12 months or the next 18 months. For example, a lot of the people doing contact tracing in the next few months, 3 months, 6 months, may be the same people we want to tap for a massive nationwide vaccination effort. And they may be the same people nationwide that we want to stay engaged in our communities to help promote health and help manage disease as we look at jurisdiction-wide community health problems. So let's fix it right the first time. And I kind of like this graphic, which I just ripped off the website, that basically has this motto, let's get it right for both COVID today and for public health tomorrow. With that, I'll turn it back over to Laura. Thank you all for the chance to visit with you, and I'm certainly happy to answer any questions at the end of the presentation today.
Thanks so much, Mike, for that presentation and for your words of wisdom. The questions are coming in through the audience chat box. To the participants, please keep them coming. We'll get to them when our final presenter finishes. Our next presenter is Amy Twarson, Health Division Director from the National Governors Association Center for Best Practices. She will discuss with us creating and implementing plans for a careful stage reopening that protects the public's health while laying a strong foundation for long-term economic recovery. Amy, I'm going to turn it over to you.
Great. Thank you, Laura. Okay, I'm going to make sure I can forward the slides. Well, thank you so much for having us today. So as you all know, the National Governors Association represents all governors across the country. And as you might imagine, we have been very busy 24/7 trying to support them as they navigate really this unprecedented crisis that we find ourselves in. So one of the things we try to do to support them, and really are so pleased to be able to share this resource with all of you and hope you find it helpful as well, is a roadmap to recovery, a public health guide for governors. And we partnered with ASTO to really help shape the document. And one thing I wanted to just call out, and I'm so glad that we had William Crozier here from the White House. One of the things we did in this document is really take a very careful look at the guidelines that the White House issued and looked as well as to other expert reports that are out there. So, there's a lot of guidance out there. This is an unprecedented time, and to help provide sort of considerations for states, we looked at across all of those other 6 expert reports and came up with a synthesis and then added additional considerations for governors and state health officials who are really going to be on the front lines on implementing. So one of the things I just wanted to orient you to is there are 10 key steps that are in this guide. The first half is really a lot of what Mike talked about building the public health infrastructure. And then the second half is really what I'm going to be focusing on, is creating and executing a plan to gradually reopen the economy. And the guide is oriented, just so you know, there's a set of recommendations for considerations by governors and state health officials. And then underneath that, there are some key operational questions, I think questions that probably you all are thinking about in your respective states. And I think it's intended to provide just a frame to think about these issues. And we know that states are going to have to take this information, apply it to their own circumstances, and figure out what makes most sense in their particular state with their particular economy and their geographic distribution. So again, this was just a set of sort of considerations that states can then apply in a much more practical way to their individual circumstances. Okay, just 2 points I just wanted to tag on to what Mike talked about building the public health infrastructure. One of the key points of the document is, states need to be ready. And 2 things I just wanted to highlight that Mike didn't get to was the surge capacity that you should have on hand and your at-risk populations. So really, when you think about starting to reopen, making sure that your states and their healthcare systems are really able to treat folks without resorting to crisis standards of care, and this is very consistent with the White House guidelines. And, we have suggestions in there around, requiring providers to report on healthcare worker infections and number of beds they have available and PPE levels and how to think about expanding the workforce. So very practical ways to understand, is your system ready for a surge if that happens? If you're past peak and you start to reopen and you have another surge, can they handle it? So I think that's a really important piece. And other parts of the country haven't hit the surge yet. So are you ready for what's coming, even as you start to think about how to open up economies? The second piece of at-risk populations, we spent some time in the report talking about those who really are going to have the most vulnerability to the disease transmission, and that includes our healthcare workers and first-line responders, older adults that are in places like nursing homes and assisted care facilities, who not only have risk because they are together in a facility, but also because of their age and their comorbidity that makes this disease just all the more deadly. Racial and ethnic minorities, I really did want to highlight that. We have seen in the data that this disease has had a disparate impact on certain populations, such as African American communities and Latino communities and American Indian communities. And so really spending some time understanding some of the historic reasons why those impacts happen, but then what can we do in the midst of this crisis to make sure that those folks are getting tested, that they're getting wraparound services, and making sure that they're going to be able to, move forward without hotspots of disease transmission, because if that happens, then that will impact many, many people sort of across the population. Justice-involved populations is another area where there is a lot of level of risk because of the individuals in the settings where they're all together, really hard to contain spread. So we have some considerations around what states can do to think about those groups. Homeless is another population we call out because they also have just limited access to health care and other sort of sanitation conditions, and really need to think through how do we make sure that population isn't getting swept up in a disease transmission when we're trying to reopen. Great. Okay, so I want to talk just a little bit about what we had in the section of the report about really opening up. And governors are, and we're so pleased with the partnership with the White House talking about these issues, as well as ASTA with the state health officials. Governors are, of course, wanting to open up their economies and, have people return to their jobs, have activity resume in states. And so there's a lot of pressure to figure out how to do that in a way that's going to protect the public's health and avoid having a spike in cases yet again once we reopen, because that would then set everybody back. And as I said at the beginning, every state is going to have a different set of circumstances to look at. Even within the state, I think there'll be variations by county, by region. So different considerations are going to actually, play into how quickly and effectively you're going to be able to reopen. But just a couple of things to highlight for you so you know what's in this report. One of the key pieces is how to develop a strong, clear communication and public engagement plan. And so we have some suggestions. I won't read all of these, but really having to gain the public's trust is the message in this, and making sure you're reaching out to the right folks to understand what the message should be, to understand where the evidence is, and to understand how to then make everyone feel okay to go back to, what you think is reasonable in your state, knowing that you have the public health infrastructure piece that you're building all at the same time. The second part of the report, second set of recommendations, is around creating a framework for reporting. And so this part of the report, we really talk about, how are, governors and state health officials going to get public input and engagement, through task force and advisory committees. And you've seen in a number of states those task forces being established to really make sure there's a broad base that's going to inform these efforts. I think there's also in this report recommendations around a public-facing dashboard of key metrics, and thinking about, how do you know from sort of a public health perspective, have you met the right sort of decrease in number of cases, decrease in number of hospitalizations, decrease in people reporting, flu-like symptoms, versus your preparedness measures, knowing that you have enough PPE and hospital beds and protections in place for essential workers, and then as you start opening up for others. So it's just, again, a set of considerations as folks try to move forward and figure out what might work best in their state. And then we have a section on setting the criteria and defining the stages. So this has the metrics that I mentioned before, but then also considerations of how do you think about moving forward, and what would be the length of time, and how do you review for surge of cases, and how do you think about reevaluating that before you proceed to the next level of social distancing? And we've seen now that there's 19 states that have released plans to reopen. I anticipate we'll see lots more in the coming days. And if you start looking at those plans, they're often a gradual tiered approach. Some use like red, yellow, green. Some use red, orange, yellow, green with different levels of how to proceed cautiously and carefully. And I think some of the governors have talked about this as like a sliding scale. So, there's the ability to kind of move forward. And then if you have to retrace steps because there's hotspot or there's, a spike in cases or hospitalizations, then you do that and you go back down the scale and then you ramp it back up. So thinking about this as sort of a gradual process. There are 7 states that have begun plans for reopening by May 1. Some earlier this week. Some this week, and some next week. And I do think some of those plans identify what are some of those markers that they're going to do as they reopen. And if you look at those plans, they're limited reopenings, right? There are certain businesses and certain circumstances in certain parts of the state. The other thing that we talk about in this report is building partnerships between public and private sectors to implement the plan. Such a key element, really understanding how, the employers in your state and your public entities are thinking about their protections of their workers and how they're thinking about preparing for this. So we have things in there just as, things to think about in terms of helpful checklists and what kind of reporting you may or may not want to require, and what are other things to think about as you want a safe reopening. And then finally, and I'll end with this, is really preparing to reassess and approve the plan frequently. So as I mentioned, this is an unprecedented crisis. I don't think we know exactly what's going to work and what isn't. I think the key, as Mike mentioned, is really having the surveillance and testing and contact tracing capability to understand when cases are reemerging and how to, tackle those quickly and effectively so there isn't sort of broader community transmission. But, this is going to be a continuum of activities, and there's not one right answer or one right way to do this. So really making sure that there's your ability to reassess and improve the plan as you see how really things progress is, I think, the message in that. And I'll end there. I'll just end with one thing that, I think partnership between you all and governors and state health officials and the White House and all the other, private sector folks out there is really critical. This is something that we're all going to have to think about and continue to adjust. And so really pleased that we were able to participate in this webinar today. So thank you.
Thank you, Amy, for that terrific presentation and for introducing us to the highlights of the roadmap to recovery guidance that went out to the governors. I'm sure it generated a lot of questions for our participants. Keep them coming, and we'll get to them after our last presenter. Our next presenter is Dr. Nirav Shah, who is a senior scholar at Stanford University's Clinical Excellence Research Center. Dr. Shah, I'm going to turn it over to you.
Thank you. I thought I'd start briefly with a little discussion about how we're starting to get data and how we're trying to interpret it. Today, you'll see a lot of different websites out there claiming different facts and figures around the virus, its spread, around how well social distancing is working and all. And I wanted to give folks, to begin with, a little bit of framework of how to think about these models. And all of these models will inform NGA and ASTO's excellent roadmap to recovery, which Hemi and Michael Fraser just talked about. I think to the extent that there's required reading today, that would be my first top of my list for things that people should understand. But as all of these models that come out there that you see, you've heard of IHME, you've heard of many others, they have different strengths and weaknesses. And they're basically different mirrors on the data, trying to help simplify complex things and not really give us the definitive answer, but help us as decision makers, as policy leaders, make better than an educated guess in one direction or another on any given topic. All of these slides will be available later, so please don't worry about that. One example of one of the many models that are out there that just opened up this past week is this website called rt.live. I have no affiliation with them. It's a very interesting model where folks are actually modeling what is the transmission rate. How much, if you're less than 1, is the virus going to spread? Or actually, if it's less than 1, the virus is not spreading. If the number is greater than 1, there's evidence that the virus is still in exponential growth mode. And it ranks states in real time, updated daily, on what the best guess is for the transmission rates in a given community. This is an example of a model. As we think about opening up states, we really want to know not only at the state level, but also at the county level, what is that transmission rate for a given community. So for example, you'll see New York's and Georgia's RT graphed over time. This is data as of 2 days ago. It's been updated since then. And you can see that based on the hammer they've used in New York to flatten the curve, shutting everything down, it looks like today that the transmission rate is less than 1, which is a good sign. Georgia today, based on the best available evidence, is a little bit above 1. And so as states like Georgia open up today, we have to think very carefully of what is going to happen. Have we flattened the curve until now, and will it go up exponentially? Are we above 1 or are we less than 1? This is the kind of guidance that we should use in real time, and the data behind this is getting better and better and better. And so you'll see many more transmission websites coming up. Another example that I wanted to share is from healthweather.us. There are 1 million smart thermometers connected to smartphones deployed across the country over the last 8 years by this private company called Kinsa. And they now have a signal of what looks like normal flu and colds in the community over using the fingerprint of every single city in America versus what is abnormal. And as of now, anything that's above and beyond normal flu activity is presumed to be COVID activity. This has been validated in 88% of states to be at least a 2-week leading indicator of where there might be COVID hotspots in the community. This particular view happens to be one of cumulative, so it's not today. But as an example, this is real data from their servers looking at Santa Clara versus Miami-Dade. And as different public health interventions went in, what happened to the actual fever curves across counties? These are the kind of leading indicators, early signals that you want to follow in your communities rather than lagging indicators such as death, which happen 2-3 weeks into someone's course of having COVID. So to the extent that you can start to get signals earlier and earlier, you want to get that. You also want to get signals along the lines of this website. This is a social distancing activity based on people using cell phones. How much are they moving around? This is GPS signals from your cell phones that are aggregated and compared to historical numbers. Unicast has provided this as a public service on their website. And you can see that people are moving around less than before. But if you look over time, they're starting to get a little tired of social distancing, and they're moving again. And that's why U.S. as a whole gets a C-. You can use this data down to the state and county level from this and other websites. I believe Google has another version of this using their data, and many other companies have started opening up their social distancing activity scores based on various data sources. Another one another website that one should follow is covidactnow.org. This is a map of how whether cases are increasing, stable, or decreasing across America, and it's available for about 2,000 counties across America as well. And what this does is help get you yet another data point on how you're doing overall and what you should be doing over the next few weeks as we try to reopen the economy. So as you think about reopening the economy, some of the most important numbers are going to be the effective reproduction rate, which I showed you that first website. What is the capacity of the health system? Are you going to overload the system like has happened in Detroit and New York and Louisiana? As cases rise, do you have sufficient ICU capacity? That's on COVID Act now. The effectiveness of interventions. This is new work. The social distancing example I gave you is but one. Now websites are starting to come up with testing capacity. Does the state or county or region have enough high quality tests to facilitate reopening? And if you'll notice, all of the plans we talked about start with adequate testing. And we have to be very thoughtful about adequate testing because you will see many tests are not as good as they claim. The two studies that came out of California with seroprevalence studies in Northern California and Southern California both had a false positive rate of 50%. That means half the people who tested positive probably were negative. And so you have to get to that level of understanding of the various tests. So we do not have adequate testing capacity anywhere in America today. We hope to ramp that up over the coming weeks, but we know that testing capacity is the number one thing you need to be able to reopen safely. Only after that do you get to contact tracing and all of the other things we need to reopen safely. I want to spend a minute talking about all of the various models that you're seeing out there, the IHME, the COVID Act Now, the healthweather.us, and how do you start to think about them and evaluate them? Well, first, do they have face validity? Does it reflect reality? Are you seeing on the ground what the model's telling you? Is it robust? Do they tell you about the assumptions and what would happen if their model was wrong by 10%, 50%, or 90%? Is it transparent? This is very important. If they don't publish how they're doing things, they could come up to very wrong assumptions. The example I'll give you is the transparency of the COVID Act Now model led to India putting 1.2 billion people under lockdown because they could understand all of the assumptions and modify it to their needs. Whereas other models have underestimated or vastly overestimated deaths, for example. Is the model clear about unknowns and limitations? And finally, has the model been vetted by outside experts? This last point is true with all of the facts you're hearing around COVID. You can't just rely on early sources. Wait until you see peer review, because if there's not peer review, you will get the wrong answer often. You will hear things about a certain medication, an antiretroviral, helping in late-stage patients until the peer-reviewed study comes out and negates those findings. Similar things happen with the unpeer-reviewed versions of the of the seroprevalence studies in California. The peer-reviewed findings ultimately came out and showed fatal flaws in many of these studies. I'll end there and leave time for questions. Thank you very much.
Thank you so much, Dr. Shaw. That was fascinating information. And thanks for wrapping up our presentations for the webinar. I just wanted to let folks know that many participants are asking about the fact sheets, state-by-state fact sheets that William mentioned earlier in the webinar related to testing capacity of the states. And these fact sheets went out to the governors, and he is going to send them to us, and we can make them available in the webinar archive. So if you'd like to access those, just check back with us next week. And the archive will be available on our ncsl.org website. You just click on the coronavirus resource page. You'll see a screen of tiles, and you click on the webinar tile, and then scroll down to this webinar, and you should be able to access those there when we get that posted. So now it's time for questions and answers, and man, do we have a lot of questions. So I am absolutely certain we won't get to all of them, and I apologize in advance. If yours is a burning question, please send it to me at laura.tobler@ncsl.org if we don't get to it today. Excuse me. So I'm going to ask the first question to William. Does the White House want to include provisions in the next COVID-19 relief package that will help with reopen efforts?
No, I appreciate that, and I'm still on, and thank you. And just to clarify, and I shared with you as well, the state fact sheets that I mentioned earlier in the call are looking broadly at the totality of the federal government support for states and localities, and not just on testing. The piece regarding testing is being coordinated and discussed with governors and state public health directors and officials, so it encourage engagement on that side in your state and local apparatus around that particular question. On the stimulus, the president has, you maybe saw one of the tweets he had mentioned, and obviously in his press conferences talking about this, so it's still something that is being discussed, and at this time I don't have additional information on that. I don't want to get ahead of myself or the president, but appreciate if anybody has any feedback or suggestions, et cetera, please don't hesitate to reach out to me directly.
Thanks, William. This one's for Dr. Shah. Given that asymptomatic carriers have contributed to spreading the virus, how can any state open up with any assurance of containing the virus from spreading unless testing applies to every state resident and visitor?
That's a great question, and we've seen from across the world the backsliding that's happened. You may have seen yesterday's story about Hokkaido, Japan, their sobering reality when they thought they had eliminated COVID in the community, and now they lifted restrictions a little too quickly, and they're sliding backwards. So we are as strong as our weakest neighbor when it comes to COVID. On the other hand, a counterpoint is the experience of Taiwan, who never closed their schools, who had business continue, and had broad testing as well as contact tracing, up to 300 contacts traced per positive case, and they're still staying open. I think one school was closed for 1 week. Otherwise, everything was, the economy was humming along. Germany as well is a great example of when you have adequate, high-quality testing in place, you can rapidly open up your economy in ways that prevent backsliding. So I think we'll learn a lot in the coming weeks we should learn a lot from what we've already seen in Europe, and we will learn a lot from our experience across states that are opening up without adequate testing in place.
Thank you, Dr. Shah. This is for Mike. Are there any federal dollars specifically allocated for expansion of the healthcare workforce?
I don't follow those lines as closely as I do the public health lines, but I know that there was some emergency funding for hospitals and health systems that would include healthcare workers. I just don't have the exact amount. It might have been $75 billion total, but I would have to refer you to the asto.org website under resources, and you'll see a funding chart that has all of the stimulus supplemental bills and what they can be used for in the states.
Thanks, Mike. For Hammy, the overall issue with reopening the economy is issuing guidelines versus imposing mandates on businesses. How is that going to be addressed?
I think it's really going to be on a state-by-state basis. One thing I didn't mention is there are some regional partnerships which are popping up on the East Coast, West Coast, and the center of the country. And so in terms of imposing mandates on businesses and how stringent states are going to be, I think you're going to see a variation. One thing we also didn't get to talk about is I think there's questions on both sides of the coin of interstate travel, and how, if one state, for example, decides that they're going to impose a lot of requirements on their employers to open up and a state next door does not, what happens, especially when you're in a state like, let's just say, Massachusetts and New Hampshire, where people are coming across the borders all the time. So I think, we are going to learn, as Dr. Shah said, how all of this is going to roll out. And I would agree with the point that in no place is there enough testing to really be able to do what you've seen in Taiwan. And so we'll see how, when requirements are imposed on employers, how they're going to report out and what the reactions will be and resulting actions taken at the state level.
This is
Thank
Mike.
you.
I'll just add on to that. Hammy's so right. I would just add, when we look at these international comparisons, I know there's always people that say, well, that won't work for us here. But really, if you start thinking about some of those other countries, and especially based on their population, a country like Taiwan, A country like Singapore, their numbers are much smaller than our entire U.S. population, and they might be more equivalent to states. And if you take those models that countries have used for the states, not for the U.S. as a whole, but as a state, the programs they have implemented are doable. Obviously, we have to have the appropriate testing capacity, but are doable at the state level. And I think that's how we need to start thinking about this.
Thanks, all. Next question. What needs to happen to allow non-epidemiologists, medical professionals like caseworkers and such to perform duties outside of their scope? Whoever would like to jump in on that one.
Well, there's been two ways this happens. I believe that the Secretary of HHS has sent a letter to governors asking them to relax scope of practice regulations specifically in healthcare settings, including standards of care implementation. So federally, there was that push. But as you all know, as state legislatures, you each control the scope of practice in your jurisdiction. And so there probably needs to be legislative activity if it's not included in the governor's emergency declaration.
Yeah, and I'll just tag on to that. This is Amy. So I actually think there's been a ton of activity on this. There's been, sort of the waiver level at the federal level where, Medicare and Medicaid can pay for out-of-state workers, and a real expansion on telehealth. We've seen an explosion on that. And there has been a fair amount done through executive order, but also boards of medicine. The state boards have been activated in some states because the federal government can't waive the scope of practice piece. They can only waive the reimbursement piece. So I have to say we've done a memo on this. If you're at all interested, it's on the NJ website, and happy to share that with NCSL. We have been tracking, and so is the White House actually through HHS, all of the activities that are happening across the states, and a lot of progress has been made, but I think there's a couple of pockets where more could happen. So,
and I'll just add on, I think this has been a great opportunity to see what is actually possible when we lift the guild-like restrictions that are arbitrary and historic, when nurses are allowed to do what they can and do well because they're trained to, but for one reason or another, physicians haven't, and I'm a physician, have not allowed them to do it at a state level. They are able to do a lot. So my hope is that as we've lifted and seen what is possible across scope of practice, that we don't roll all of these restrictions, arbitrary and historic restrictions, back in after the COVID crisis is over.
And are there any HIPAA considerations with that?
I think everyone is being trained well in HIPAA before they, to the extent that nurses and frontline workers, we all have to take the same courses every year or more frequently. To the extent that I haven't seen any HIPAA major failures happen as a result of this, it's TBD, but I think we're all aware of the protections that need to be in place.
So I have two last questions. We may go a little bit over top of the hour, but this has been such a great source of information for folks. Bear with us. If you have to leave us, thank you for joining us. We won't be but 5 more minutes. So are the states that are planning to open up prepared with the public health testing and tracing infrastructure that you all have been talking about as being so important?
I think as a professor, I can say what I believe more freely than some of the others on the line. Look to the experience of those who have succeeded, Taiwan and others, and see what they test, the number of tests per capita, not the total number of tests, the number of tests per capita, and then make your own judgment.
Thank you. Anyone else? So there were several questions that came in on antibody tests and just general questions about how they will be used and who will be prioritized for them, and I think just general questions about how the availability of antibody tests will help with the reopening of the economy. And I will put this out to you if you have any additional words of wisdom on that to share it with our audience.
Dan,
I'll briefly say that I've had a lot. Go ahead, Hemi.
No, you go first. You're the doctor.
No, I've had lots of my patients asking me for it. There isn't sufficient capacity. We still don't even have sufficient capacity for PCR tests. So for looking at active infections, there's not sufficient capacity for that even. So the antibody test is a wild west right now. Everyone and their brother is developing them. They are all over the map in terms of their reliability. I think it'll be at least a month before we start to see data that we believe of which tests are reliable at scale. Tests such as the Abbott test are not yet proven. Until you see peer-reviewed evidence on any given question, I would hold judgment either positive or negative.
I concur.
Thanks. Was there anything else that you wanted to add, Amy?
No, the only thing I would say is we addressed it as a question in the roadmap because we are getting a lot of questions on it, and I do think we're just going to have to wait and see and be patient. There has been some discussion sort of at a policy level about the healthcare workers would be top priority and figuring out if they're immune, but until we have the real reliable tests, we can't rely on that. So to be determined.
Terrific. Well, I'm going to wrap us up. Our webinar will be available by archive on our www.ncsl.org website. Please refer people to it if you found this to be helpful. I want to thank our presenters again. Let's give them a virtual round of applause. I learned a tremendous amount in this last hour, and I'm very grateful for them in giving us their time and expertise. I want to thank you, participants, for taking the time to be with us on our webinar this afternoon. I hope that you all are using the resources that we have on our COVID-19 resource page, and I encourage you to visit the archive for this webinar, where we hope to post some additional resources that were mentioned throughout the webinar. I once again thank our presenters, and I thank you all for joining us. I hope you're staying well, and our webinar is now adjourned. Take care.